right, we'll let folks roll in, but we'll get the process started here. Good morning again, everyone. My name is Jordan Hensley. So glad to have you here with us for our June coffee and conversation session, and incredibly pleased to be joined by Ken Norton, who is the Executive Director of NAMI New Hampshire, which is the New Hampshire chapter of the National Alliance on Mental Illness. Ken led the development of NAMI New Hampshire's Connect Suicide Prevention Program, which is a national best practice in suicide prevention, intervention, and postvention, which has provided training across the US in over 25 tribal nations and 5 countries. Ken has participated in numerous commissions and work groups in New Hampshire and nationally, and has served as the subject matter expert for SAMHSA, the Department of Defense, and the Veterans Administration, and presented nationally and internationally on subjects related to mental illness, suicide, and media and messaging. Ken has worked in community mental health, served as a licensed foster parent, and has lived experience as a family member with mental illness, addiction, and suicide. Ken, so glad to have you with us this morning. Welcome. Glad to have you here.
Great to be here, and it's an honor. Carsey School is a New Hampshire treasure, and you folks do great work, and pleased that you invited NAMI to present.
Welcome. Well, that's great. We will get, I guess we can just get rolling with the presentation here, if you'd like.
Okay.
And then, folks, as Ken's getting that up on the screen, if you have questions, you can please type them into the Q&A box, and we will get to them at the end of the presentation.
So thank you all for coming, everybody, and spending your early morning or part of your morning, or maybe it's midday for you, with us. And it's good to be here. And really going to talk about mental illness, and mostly focus on serious mental illness, but really trying to present seeing people as people and not as their illness. Let me see if my... Just an outline for what I'm going to talk about. I'm going to say a little bit about language, and then give an overview about NAMI for people that are not familiar with NAMI New Hampshire. And then, we talked about the title of this being New Hampshire's Mental Health System, Past, Present, and Future. Really going to start around 50 years ago with deinstitutionalization, and then go from there. So not going to go way back. And talk about some of the impact of mental illness, and then about how that plays out in New Hampshire, a little bit about what we can do, and then hopefully have plenty of time for questions and discussion. So I want to start by just saying a little bit about language that really encourage people to use first-person language. We shouldn't be saying he's schizophrenic or she's bipolar. Or they're an addict. Recognize that some people, particularly in 12-step programs, may choose to call themselves an addict, but we should be careful about how we frame somebody. And again, they are not their illness. And then when we talk about suicide, there are terms that are somewhat challenging that have become pervasive in our language, starting with the term committed suicide. And a lot of people, particularly who have lost a loved one to suicide, don't like the term committed, because it's often associated with negative acts like committed a felony or committed a crime or committed adultery. I choose not to use the word because I think it belies what we know about suicide, which is that even for people who have made highly lethal attempts and survived, they admit to having been very ambivalent in the immediate time right before that attempt about whether they wanted to die. They wanted their hopelessness and their psychic pain to end, but they were not necessarily committed to death. And then how the term successful suicide or failed suicide attempt got into our language is beyond me. Obviously, we don't want people to die by suicide. And then we talk a lot in the mental health field about stigma. But I would challenge you to instead use the words discrimination or prejudice, and I'll be saying a little bit more about this. Stigma is kind of this nebulous term, as opposed to when we talk about discrimination or prejudice, that activates a sense in all of us that there's a wrong that needs to be righted, and I think propels us to think about taking action about that. Where stigma, we just kind of shrug our shoulders and, there's nothing really that we can do. And I want to make clear that there's no us and them when we're talking about mental illness. I'm somebody that's had thoughts of suicide my entire adult life. I've never acted on them, but sometimes they were really quite intrusive. And I'll also give a little rant about the term behavioral health, which I find offensive. I find it offensive as a family member and as a parent, because, I think it contributes to that myth that people just, it's a behavior problem, and if they straighten up and fly right, that everything will be okay. I also think it's a confusing term, that it's used sometimes when it means mental health, sometimes when it means substance misuse or addiction, sometimes when it means both. Obviously, it's a shorthand, and it's a lot easier to say behavioral health than mental health and addiction, or mental health and substance misuse. But it really, it really comes from the corporate world. It comes from insurance companies. And I think the other thing that I'll say about it is that in 40 years of working the mental health field, I've heard people describe themselves in various ways, some of which I would never use or repeat, but I've never once heard someone say that they have a behavioral health disorder. NAMI New Hampshire was founded in 1978 at the kitchen table of Peggy Straw, who found herself widowed in her mid-40s with an adult daughter with serious mental illness. And she reached out to other families in New Hampshire and nationwide. She went to a couple meetings in the Midwest that turned into the creation of NAMI as a national organization. And back then, there was some significant dynamic tension, as there is now, about what we need for people with mental illness, and meaning that many of those families felt that in the era of deinstitutionalization, and I'll be saying more about that what we needed was more hospital beds. And Peggy stood up and made a passionate speech at this gathering of 200 people, saying that if that's what this organization's going to be about, she didn't want any part of it. She wanted something more for her daughter than to be in a day dress on a ward of a state hospital for the rest of her life. And her side prevailed. Peggy was elected as the first vice president of NAMI nationally, and came back to New Hampshire and put a sleeping bag in the back of her car and drove around the state meeting with other families and organizing what came to be NAMI New Hampshire. And our mission is that we're a grassroots organization working to improve the lives of all people affected by mental illness and suicide. We're not treatment providers. We do that through support, education, and advocacy. And while we have an amazing and talented staff, which now numbers 50 people, we're only able to have the reach that we do because of the passionate volunteers that we have. We're a statewide organization, and many of our support groups, our educational programs, our advocacy, all of that is done by volunteers who have lived experience themselves with mental illness, either personally or as a family member. And our vision for how we move our mission forward is that we want a future where people affected by mental illness have hope, help, and health, and are able to access supports and evidence-based treatment necessary for recovery, have a lifespan that's not cut short by suicide or co-occurring conditions, and reach their full potential living in their communities free from discrimination and stigma. We reach about 35,000 Granite Staters each year, and in a variety of different ways, some of that web-based, and particularly during the pandemic, a lot of that been web-based, our educational programs and support groups. And again, thanks to our volunteers who have been really adept at making that switch. And we have the largest awareness and fundraising event in New Hampshire, our NAMI Walks. It will be our 20th year. We welcome you to walk with us virtually on October 10th in 2021, and there's more information about our website. I will also say that we're a membership organization, and we are only able to do the work we do because of donations. So if you're not walking, donate to somebody that is. And also today's New Hampshire Gives Day, and we welcome donations as part of New Hampshire Gives. Okay, moving into the next part, this is my take on things, that the long history of prejudice and discrimination and negative attitudes toward people with mental illness have had profound consequences. And as I said, we're going to start in the late 1950s, and I think that this is a pivotal point for us, because in 1957, we hit the peak census at New Hampshire Hospital, our state psychiatric facility, with on the grounds of that hospital in Concord, there were 2,700 adults at that time. And there was a farm, a working farm, laundry, kitchen, people, worked at the facility, so to speak, patients. And our population as a state was 750,000 people. When I first became a case manager in the early 1980s, many of the folks on my caseload had spent 30, 40 years at New Hampshire Hospital, and some of them were in the process of being discharged. And when we look forward to now, 60 years later, the census at the state hospital is 174 adults. And then there are 62 designated receiving facility beds, and those are beds around the state at local hospitals or other centers where people can be admitted involuntarily. And there's 35 children at Hampstead Hospital, sorry for the typo there. And our population has grown by 500,000 people. And so that's, I think, the real context of looking back to and looking forward to where we are now. So where did everybody go? And I'll be talking about that more in detail. But the first thing I want to say is that that what we don't see are the successes. They're much more hard to see. The many people who are living successfully in the community, close to their families, raising their own families with mental illness, that might have been one of those 2,700 people 50 or 60 years ago. And so there are many, many, many successes of people who with serious mental illness who are doing well and who are thriving. But that said, that there have definitely been negative consequences from deinstitutionalization as well. So, one of the obvious ones is the number of people who have ended up incarcerated. And while this is a little bit old, I think it tells a pretty good picture. And what we're looking at is the green line starting at the bottom left is the number of people with serious mental illness in prisons and jails. And then the gray line or brownish line is the number of people in mental hospitals, and then the red line is combined. So, you can see that the number of folks that were incarcerated in the 40s, 50s, 60s till mid 70s was quite low, and the number of people hospitalized much higher. And then they crossed around a little before 1980 with the number of people with serious mental illness being released from hospitals, but dramatically increasing in terms of their incarceration rates. And, this gives another little look at this. These numbers are really hard to quantify, but, I'm sure you have all heard that, the statement that the largest mental health facilities in the state is wherever, Dade County Jail in Miami, or the Los Angeles County Jail, or the Cook County Jail in Chicago. And I think it's important to kind of note that there are definitely higher percentages of people with mental illness incarcerated in our local jails than necessarily in our state prisons or our federal prisons, but still significant numbers there as well. And that really speaks to the role of law enforcement that they were forced into when deinstitutionalization occurred, in terms of them being on the front lines. And what we need, and I'm going to say a little bit more about later on, are new models for response to mental health crisis. Individuals and families need something other than having to call 911 or go to an emergency department when there's a crisis. I think it's important to note that 45% of officer-involved shootings in New Hampshire or officer-involved killings are people with known mental illness, and that's significantly higher than the national average. And police really need more training and better training in terms of use of de-escalation techniques and non-deadly force when responding to people with mental illness. The other thing that's become very apparent in recent years, should have been apparent much longer ago, is that there are very high rates of depression, trauma, and suicide for law enforcement and first responders. More law enforcement officers die by suicide than die in the line of duty every year. And there's an ongoing need for them to have peer support and services that are available to them to meet with the unique mental health needs that they have. And one of the other big areas that we obviously see relative to deinstitutionalization is homelessness. And again, statistics vary, but some say about 1/3 of homeless people have a serious mental illness, mostly schizophrenia or bipolar disorder. And that's obviously for people that are chronically homeless, meaning, over a long period of time, that percentage is much higher. Statement that more people with untreated severe psychiatric illnesses are living on our streets than receiving care in hospitals, and obviously very high rates of co-occurring mental illness and substance misuse or addiction. Also very high rates of victimization in general for people with mental illness, but specifically for people that are homeless, and trauma as well. And those rates of victimization obviously much higher for women than for men. And when we talk about serious mental illness, one of the things that should be talked about more but isn't, is that according to the National Institute of Mental Health, the average life expectancy for people with serious mental illness is much lower than the general population, and they die 14 to 32 years earlier. And part of that, they say in these studies that it's not necessarily related to suicide, which I'll speak about in a moment, but it's about high rates of addiction, obesity, diabetes, some of that coming as side effects from medications. Certainly weight gain is one of the serious side effects of antidepressants and other medications, but it's also that they have poor health care and poor access to health. And that's something that we collectively have been trying to address in the mental health world over the last few years, and in New Hampshire through the integrated delivery networks that have been operating in 7 regions of our state for the last 5 years. A little bit about suicide. This chart is from the Center for Disease Control. It's the 10 leading causes of death in New Hampshire between 2015 and 2019. On the horizontal axis, you have age groups, and on the vertical axis, you have starting at the top and going to the bottom 1 through 10. And what we're looking at is the green. And what we see is that in New Hampshire, suicide is the second leading cause of death from ages 10 through 34. It's the third leading cause of death, ages 35 to 44, and it's the fourth leading cause of death, ages 45 to 54, eighth leading cause of death overall. Blue is unintentional injury, and that's where we would see drug overdoses. And we know that some of those Some of those blue deaths are likely suicide deaths, single car accidents or drug overdoses where the medical examiner has been unable to determine whether it was intentional or accidental. And we hear very little often about the high rates of suicide in our society. When we hear about gun violence, most of that is directed at homicides, and yet gun suicide deaths outnumber homicide deaths almost double in our country. I'm often asked by the media about, and I should also sort of note that since that period of deinstitutionalization, and I can't say that it directly correlates with it, but we have definitely seen a significant rise in suicides over the last 50 to 60 years. I'm often asked about, the whys about that. And I used to give very complex answers about, economics and war and recession and whatnot. And now I simply say it's because we as a country and as a state have done very little to prioritize suicide as a public health issue. And that includes research at the federal level. And those deaths are just the tip of the iceberg. This data is a little bit old, but it just gives you a visual representation of, and what it doesn't show are the people that may attempt suicide or have thoughts of suicide and never go to an emergency department. But you see at the bottom of the pyramid, almost 500,000 people come to the emergency department as a result of a suicide attempt. Almost 250,000 people hospitalized, and then the suicide death rates rising. Although in 2020 the rates went down, and there's a lot of discussion in the suicide community about what that means and how to interpret that as a result of the pandemic. And I won't go into details around that. So, moving along into a little bit more about New Hampshire's mental health system. During the 80s, we were late to deinstitutionalization compared to other states. And that was an advantage for us because we were able to learn from their mistakes and their successes. And we built a very strong system of community-based care in our community mental health centers. We built a new acute psychiatric services hospital that opened in 1990 when everybody else was closing down their institutions. We were opening a state-of-the-art hospital that included a contract with Dartmouth to provide psychiatry and have it be a teaching facility, which dramatically increased the level of care within the hospital, being much better than many private hospitals. And we had those regional designated receiving facilities, which were supposed to be all around the state for short-term admissions, but which slowly closed, and I'll say a little bit more about that in a minute. And we were rated #1 in the US as a state in the early 1990s for our mental health system, at which point Peggy Straw, our NAMI New Hampshire founder, was quoted in the press as saying, "Great, we're the smartest kids in the dumb class. If this is the best we can do in the US," it was said not without pride, but if this is the best we can do in the US for people with mental illness, it's not saying much. And then, as we look on into the next decade at the turn of the century, things went downhill from there, and pretty dramatically so. We saw the loss of private hospital beds and community residences, closure of day treatment programs, which were operated then by all of the community mental health centers. Seeing all this, there was a mental health commission formed and a 10-year plan developed in 2008. The recession hit shortly thereafter, and essentially none of the what was recommended in that 10-year plan, which I should mention never spoke about children's mental health, was funded. And we saw as part of that, those cuts, the closure of the Phil Brooks Children's Center on the grounds of New Hampshire Hospital, saying that there wasn't sufficient funds to do renovations or whatever. However, 3 years later, the legislature appropriated $3.1 million to renovate the building and to use it as office space. And I will note that Commissioner Shibinette, very forward-thinking, reopened Philbrook last year, evicted essentially those state office folks and reopened it as a transitional housing program on the grounds of New Hampshire Hospital. So, a bunch of things happened at the national and state level during the following decade, starting with a federal class action suit, which I'll say more about, the emergency department boarding crisis, the Affordable Care Act and Medicaid expansion at a national and a state level, the development of a system of care for children, due process class action suit about emergency department boarding, a new 10-year plan, and then the impact of COVID. And we'll be touching more on some of these subjects. So the first thing was that in 2011, the Federal Department of Justice sent a letter to the state of New Hampshire warning that we were in violation of the American with Disabilities Act and the Olmstead provision in that. And for those of you that may remember, we had a Tea Party legislature at that time, and we were still on the tail end of the recession. And they essentially thumbed their nose at the warning letter. And so in 2012, legal advocates led by the Disabilities Rights Center in New Hampshire filed a class action suit in federal district court. And that class action suit was joined by the U.S. Department of Justice against the New Hampshire Department of Justice. That suit, again, only mentioned adults. There was no mention of kids for a variety of reasons. And in 2014, that class action suit was settled by then Governor Hassan, with some key components being the creation of 3 mobile crisis response teams in successive years, starting in Concord, then Manchester, Nashua, assertive community treatment teams or ACT teams at all of the community mental health centers, more supported employment, some very specific recommendations for Glencliff, which is the home for the elderly way up north, and transitioning some of those folks back to the community. And then the court appointed an expert reviewer to look at New Hampshire's progress and to issue reports twice a year. That settlement agreement is still ongoing. The expert reviewer doesn't feel that we are in full compliance as a state with that. So that was a big turning point for us as a state. Interestingly, that suit never mentioned emergency department boarding because it really only had started to begin in late 2011 or early 2012. But by the end of 2012, it was a crisis. And NAMI New Hampshire held a press conference in January of 2013. We said that it is wrong medically, legally, ethically, morally, and economically. And then a number of things have transpired since that time, including most recently, which I'll talk a little bit more relative to the Jane Doe decision around emergency department boarding. Emergency department boarding is clearly the most visible symptom of the lack of access to, for people with serious mental illness in the state. What you're looking at is a chart of the black is adults, the dark blue is children, and it goes from April of 2015 through the end of May of this year. And there are some seasonal spikes, which you might notice. For instance, these typically go up every May, but you'll see that that there was a spike for children back in February. We hit a high point, 51 children in emergency rooms. I mean, just heartbreaking. And combined during that period of time, high 80s, adults and children. And so you can clearly see that trend too, that when the pandemic starts, those numbers of people being boarded in emergency rooms start to trend upward, both for adults and children. And we had been making considerable progress, particularly on the adult side, prior to the pandemic. The Jane Doe decision was released by the Supreme Court a month ago, and that involved a habeas corpus, which is an emergency hearing where you ask for the body to be released, saying that somebody's been detained inappropriately. Jane Doe filed a habeas corpus petition in Grafton County Superior Court after being detained in the emergency room at Dartmouth. For a variety of reasons, although it's supposed to be an emergency hearing, it was not heard until they were moved to Concord, and then it was heard in Merrimack County Superior Court, and the judge ordered Jane Doe released based on some of the decisions or the writings of the judge in the federal district court case, John Doe case, which I won't get into in a lot of detail, but NAMI New Hampshire filed an amicus brief along with the ACLU and the New Hampshire Hospital Association. Our brief did not outline legal arguments. It really looked at the human impact and some of the legislative and policy attempts to address emergency department boarding. And in that decision by the New Hampshire Supreme Court, they affirmed the lower court's ruling and essentially unanimously and said that the 72-hour clock for having a hearing to determine whether there was probable cause starts at the point that the person is detained in the emergency room, not when they're finally admitted to a hospital. And that's what we had been saying since 2013. That people in a mental health crisis, our position has always been people in a mental health crisis should be immediately transferred to an inpatient setting. On that day of the decision, there were 43 adults, 26 children being boarded. Governor Sununu issued an executive order 48 hours later, and a number of steps have been taken. And as of 2 days ago, there were 0 adults waiting and 33 children. And then want to say a little bit about the children's system of care, because I mentioned in the mental health 10-year plan in 2008, it didn't talk about children. The mental health first lawsuit didn't talk about children, and technically the Jane Doe decision, since children are admitted voluntarily, quote unquote, under the authority of their parents or guardian, the Jane Doe decision doesn't apply to them either. But the Endowment for Health had prioritized the mental health needs of children for quite some time, and a work group was started around 2009 or 2010 to look at developing a children's system of care, which is a federal model, or a national model, I should say, that's family-driven and youth-guided, and focuses on being culturally effective for the needs of those families. And from that came the New Hampshire Children's Behavioral Health Collaborative, and which operated for a few years. And then during that whole time, Commissioner Myers decided, with input from NAMI New Hampshire and other groups, to one of his first acts as commissioner was to create a Bureau of Children's Behavioral Health within the Department of Health and Human Services. That group worked very closely with New Hampshire's Department of Education, Office of Student Wellness, which was created around the same time. And there's now a statewide fast forward program that serves families at risk of having a child placed outside of the home, and currently serving about 300 families in New Hampshire, I think. The new 10-year plan, and I'm going to say more about that, had a lot of focus on children, and juvenile justice reforms that have taken place parallel to the children's system of care have resulted in the legislature considering closing the Sununu Youth Services Center, which is a pretty significant change for our state. One other thing that's been very important through the whole process of deinstitutionalization is parity, or the lack of parity. And parity is that that insurance providers cover mental health treatment in the same way that they would cover medical or surgical treatments. And prior to some of the federal legislation, the Mental Health Parity Act and the Affordable Care Act, there were lifetime caps, there were high copays, there were pre-existing conditions that all served to discriminate against or deny people with mental illness access to services. The UNH Health Policy Institute has been a real leader around addressing parity issues in our state. And the New Hampshire Insurance Department created a mental health and addiction advisory committee. I believe that was back in 2016 to address some of these issues, including consumer education. In 2017, there was a national report done by Milliman, which is one of the largest insurance actuaries in the country, and they particularly cited New Hampshire for having significant disparities in parity. So, for instance, if I were to go to my cardiologist for a 15-minute med check, and she were to use code ABC for that med check, and then the following week I went to my psychiatrist for a 15-minute med check, and he used code ABC, he would be paid upwards of 70% less than the cardiologist for that same 15-minute visit for using that same billing code. In 2018, the New Hampshire Insurance Department conducted a market conduct analysis where they looked at claims data and compared claims data for mental illness compared to other physical health conditions. And they released a report in 2019 saying that they had found significant disparities, and the insurance department entered into an agreement with Anthem and Harvard Pilgrim to correct those situations. That parity challenge contributed greatly, in my mind, to significant workforce shortages, which we're currently experiencing in our state. And that's across the board, from psychiatrists to psychologists, social workers, nurses, peer support specialists, mental health workers, all down the line. When reimbursement rates are really low, then that results in low salaries. And if you're, let's say, a medical student and you're looking at a specialty area and you're looking at $300,000 in student loans, and you're saying, well, I could be a psychiatrist or I could be an oncologist and I could make, this much more if I were, this area. Maybe that's something that considers into your decision making. But certainly one of the biggest challenges we face right now in New Hampshire are workforce shortages. Then the 10-year plan came out in 2019, and it really, had a lot of input from the public, and 14 priority recommendations, including children, peer support, community-based services, mobile crisis, and a lot of them were funded in the 2019 legislative session, but the pandemic slowed the operational movement of those moving forward, and significant progress being made on that in the current legislation as well. When I talked about the need for reforming mental health crisis care, Congress passed in last October an act creating a national suicide prevention 3-digit hotline, or 988. It will go live nationwide in July of 2022, and it's really been a catalyst for across the country for mental health crisis reforms, and looking at the whole mental health system in terms of the role of law enforcement versus mobile crisis teams, and how we can change, again, giving people that opportunity to call 988 in a mental health crisis rather than go to the emergency room or get involved with law enforcement. And our Department of Health and Human Services has convened a stakeholder meeting, which includes folks from the Department of Safety and all across the state, and that's preparing for implementation of 988 in New Hampshire. And then, would be remiss if I didn't say something about the pandemic, the increased stress, anxiety, and depression across the lifespan. All across the country, significant increases being reported, particularly hitting children and young adults hard. That's had a big impact, as I mentioned, on emergency department boarding, but silver linings that for telehealth, low cancellation rates because people have more access to treatment, increased media coverage, and that's resulted in significant federal investments in mental health care. The big unknown here is what will be the long-term mental health impact by the pandemic. And then as we look towards the future, there's very strong bipartisan legislative support in 2021 for for those continuing the movement on New Hampshire's mental health plan. It's being driven in a large part by the funding through the American Recovery Plan and doubling of mental health block grant funding. Governor Sununu announced last week $100 million in funding to expand mobile crisis statewide, to develop critical time intervention, which is another important program that addresses recidivism or returns for hospitalization. The creation of a new forensic hospital in the state, which has been talked about for a number of years, adding more designated receiving facilities, beds at local hospitals and in the community, and adding community residential beds. So, just want to kind of conclude by what can we do, which is often a question that I get asked. And the first thing is to acknowledge mental health conditions and addiction or illnesses. And if you have been personally impacted by it or have a loved one, being open about that is really helpful. It's those personal stories that change people's hearts and mind. And we need to demand adequate funding for mental health and addiction across the board, for treatment, for prevention, and for research. We need to promote recovery-friendly workplaces and communities. We need to promote peer support and alternative treatments. And, bring a casserole. If your next door neighbor is, admitted to a hospital for a mental health condition or has a loved one who, attempts suicide or dies by suicide, reach out to them. And then the last thing is to vote, and certainly contacting legislators, particularly as we're in the final throes of our budget, to tell them that you support the increased funding for mental health would be very important. Also recognizing that, that we all have a role preventing suicide, watching out for warning signs, which can include talking about death or suicide, hopelessness, mood changes, anger, increased drug use, isolation. And again, that 988 number will not go into effect until a year from now. So the number remains 800-273-8255. And just remember that to try to give hope, and that one person can do a lot. And with that, I'm open to any questions or discussion that people have.
Wonderful. Thanks so much, Ken. That was a really great overview of everything that's been going on and is going on in New Hampshire. So folks, again, you can use the Q&A box to put any questions in there that you might have for Ken. So I'll kick things off here. I'm just thinking, from a policy standpoint, I'm curious what you think both from a policy perspective, what is low-hanging fruit that New Hampshire really needs to enact as soon as possible in terms of mental health policy, and what is something that you would like to see, if money were no object, what's kind of the gold standard of just something that the state should enact in order to better support folks with mental illness?
Sure, great questions. Thanks, Jordan. I think from the policy standpoint, statewide mobile crisis response is something that we've been advocating for since the emergency department boarding crisis started. Those mobile crisis, response teams are teams with a mental health trained person and a peer who is also trained. And that can, make a huge difference in terms of going to somebody's home or meeting them, in a public place where they're comfortable. And certainly results nationally indicate much fewer hospitalizations and much fewer incarcerations when mobile crisis. So I think that would be, in my mind, the low-hanging fruit. And then, the kind of magic wand question, there are programs around the country built on that. And I would say, for me, 988 is, another huge policy piece, another big part of that. And I was involved at the national level in advocating for that. But there's a program called the Fusion Model, or the Living Room. And it started in Arizona and has been modified, but they have something like, over the last 3 or 4 years, not turned away anybody brought to them, either voluntary or involuntary, for any reason. They're greeted at the door by a peer. And the turnaround for law enforcement is less than 5 minutes when they bring somebody to to this facility. And obviously, in order for that to be successful, there has to be, strong continuum of supports behind it to move people through that facility. What do they need? An assessment? Do they need 24 hours? Getting them housing on the other end and treatment. But seeing something like that has a strong peer component and provides, doesn't turn anyone away is something that I would love to see us have in New Hampshire.
Awesome. Thank you. So we've got a few questions in here already, and folks feel free to add more as the conversation continues. The first one we have is from Pete. It says, Ken, thank you, first of all, for your work with veterans. And his question is, percent of the 35,000 touched vets? I'm not exactly sure. Pete, we might ask you to clarify a little. Do you know what he might be referring to there, Ken?
No.
Okay. So Pete, just ask you to clarify if you're still on with us, and we'll see if we can get that answered here for you. Could you talk maybe a little bit while just like on the topic of veterans? Is there anything specific that NAMI New Hampshire does working with veterans?
And yeah, thanks, Pete, for that question. I think that one of the things that has really promoted better mental health treatment in our country has been the recognition that when our strongest men and women are impacted by mental health issues, and particularly veterans coming home from the recent Iraq and Afghanistan wars, but I think, a recognition that we did poorly relative to Vietnam vets and other veterans. Very high suicide rates, and certainly a lot of work with them. Again, a lot of progress made in the involvement of peers in treating veterans. NAMI New Hampshire has separate veteran support groups online for veterans and their family members. We have an educational program called Homefront for family members of veterans with mental health issues, and nationally do a lot of work as well. And we've worked closely with the New Hampshire National Guard around suicide prevention efforts, and work nationally with the Department of Defense around responding after a suicide death, or preparing hopefully a better response in the event of a suicide death, to reduce risk and promote healing among military and families.
Thank you. Oh, and Pete responded here. He's saying the percent of the vets of the 35,000 that you touch yearly.
Oh, it's a good question, and I don't know. I don't know off the top of my head the answer to that. But at different points in time, we've done a lot of programs, specifically for veterans and for family members. Yeah, I'm sorry, I don't know what percentage that is.
He also says, nice photo in front of the helicopter.
And I should say that picture was the first training in the country around responding. It was in New Hampshire, around responding, how to respond more effectively to suicide deaths in the military. Folks flew up from the National Guard in South Carolina to participate in that training. And then that was something that we moved on with the whole Department of Defense.
Nice. So we have another question here from Dennis. It says you talked a lot about mood disorders. What is the status of personality disorders?
Thanks for that question, Dennis. And personality disorders are kind of this subgroup of major mental illnesses, and they're often not necessarily, with the exception of borderline personality disorder, they're not considered something that would provide admission to New Hampshire Hospital, for instance. And they are personality characteristics or patterns of coping that may often be harmful to that individual and to others. Borderline personality disorder is the exception to that. Some people describe that the borderline is that it's kind of part way between schizophrenia and a mood disorder, although, there is that classification of schizoaffective disorder that covers both of those, but very high rates of trauma for people with that diagnosis. And certainly one of the things that we've seen in recent years is through the ACEs study, the Adverse Childhood Experience studies, longitudinal studies showing that adverse childhood experiences impact across the person's lifespan, whether it's high rates of dropping out of high school, high rates of suicide, high rates of divorce, high rates of job turnover, and more recently, research showing that trauma can be passed down genetically. So when we look at historical trauma for indigenous populations, racism and Black people, people of color, Jews, other persecuted populations, that historic trauma can impact on genes and be passed down to the next generation.
Wow. We have another question here from an anonymous attendee. What are your thoughts on the role of value-based payments to drive improvement in the mental health system?
Thanks for that question, and it's a challenging, the whole. I mean, I guess I would start by saying that that for me, I think that our whole healthcare system being driven by insurance providers is problematic, and that when we look at spending more per capita than any other country in the world on healthcare and having terrible outcomes. If you just look at two key outcomes that are measured, our infant mortality rate is somewhere close to 40th among countries in the world, with countries that we would consider, quote, third world or undeveloped countries ranking much higher than us, and life expectancy being somewhere in that same category. So, we spend a lot of our healthcare dollars going into insurance companies and administrating health. And so, that value-based piece can gets, drills down a little bit at these different ways. How should we organize payment? Should it be focused on performance? Are there ways to manage care, for instance, which, managed care started as a really good thing in the mental health field, because at the time there were these gold-plated insurance policies, and people went into hospitals and stayed for 9 months or a year. And managed care said, no. We're focused on more community-based care now. We're going to get you, short-term hospitalization. We'll get you stabilized. We'll get you into a day treatment program. We'll, get vocational supports. We'll get you back on your feet and in your, home community, instead of these very long and costly mental health admissions. But it's now become where, managed care becomes about saying no and putting up barriers to reimbursement. So it's the whole mechanism of insurance-based care that we have, I feel, is problematic to people accessing care and getting good health. I will also say a little bit more and say that when we look at a situation like emergency department boarding, and that's really the tip of the iceberg, that we, not seeing are that sometimes 6 week, 3 month waits for an outpatient appointment. And that's for people with insurance. Insurance providers are supposed to have adequate networks of care for people within their system. And obviously the fact that people call all of the providers in their network and are told, no, we're not taking new people, or they can't get admission to a hospital, shows that insurance companies need to do more relative to providing adequate networks of care for mental health.
Thanks. That's really interesting. Joyce says, thank you for your excellent presentation. She has a question regarding transitional and supported housing in the community. is there currently funding in the state budget to develop and increase these services? And which agency will be providing these services, DHHS or New Hampshire Housing?
Thank you for that question, Joyce. It's really important. And I think that, just giving a quick historical perspective that, that back in the 80s, all the community mental health centers had some type of community-based residential programs. And as we moved into the 90s and 2000s, those fell away for a variety of reasons, reimbursement rates and other things. And then the state operated on the grounds of New Hampshire Hospital during that time, the 90s, 2000s, the transitional housing program there, that was taken over by NFI probably maybe 6 or 7 years ago. They've done a great job with that, and they've now expanded that into a couple of areas. Bethlehem, I think they'll be opening a new one in Rochester this year, and one in Manchester. The state then repurposed the Philbrook building back into a transitional housing program, within 90 days, did a remarkable job with that and opened it last September. That is providing 16 beds, I think. In the proposed budget that is now has passed the Senate and will go to a committee of conference, there is significant funding for supported housing for all of the community mental health centers, as well as some additional community transitional housing that's been proposed and advocated for by Governor Sununu in that budget. So hopefully that goes through, and that will really help with what has been the backdoor problem, which is that people that are hospitalized then aren't able to transition from the hospital when they're ready because there's not available and safe places for them to go.
Thanks, Ken. And just as a follow-up, I'm curious, New Hampshire is obviously the housing market the last several years, but in particular lately has really been heating up. Things have been getting more expensive. Have you seen an impact on that with folks and being able to get into housing, or folks being displaced from housing that might otherwise not be, due to mental illness or anything like that?
Yeah, really important point, Jordan, and thanks for making that. It's really across the board, because not only does it impact on people with mental illness, which I didn't talk about, but they experience much higher rates of discrimination in housing than the general population. If a potential landlord says, well, where do you work? Oh, well, I'm not working. Well, how are you going to pay your rent? Well, I get disability. Oh, well, what's your disability for? Or where have you lived before? Well, I'm living at New Hampshire Hospital right now, or I'm in this housing, transitional housing program. But it also impacts on the workforce. And, and what we're hearing from employers is that in some areas of the state where housing, to your point, is really tight all across the state right now. But in some areas where it's really state tight, that employers are looking to recruit people from out of state, and they may successfully get a candidate that's interested in moving, and then that person looks for housing, and there's no housing to be found, or housing is really costly. So affordable housing is a significant issue. There is, again, more funding both at the state level and the federal level for more affordable housing, but that's going to take time to construct for some of it, and to impact on the current shortage in the housing market. And we've also seen the pandemic impact of people from the cities saying, hey, I don't need to work in my office anymore. I'm going to move to New Hampshire, and certainly that's taken up a lot of available housing as well.
Yeah, thank you. We had a follow-up question as well from Joyce about what NFI stands for.
I think it's Northeast Family Institute, but they go by NFI. So that is their trade name. But yes, it's part of a regional program in New England that is under the umbrella of Northeast Family Institute.
Great, thank you. Another question from Dennis asking, what's currently happening to combat vicarious trauma for providers and frontline people in facilities?
Excellent question. Thank you for that, Dennis. The short answer is not enough. And it's something that, that we don't talk about enough in the mental health field. One of the things that's important to acknowledge is that, people who have been determined to be a danger to themselves or others can sometimes be violent. And one of the things that we've seen with emergency department boarding, and I think that's been demonstrated, is that when people aren't treated and they're being held, there's an increase in their aggressiveness. So that potential trauma for frontline workers is significant and real, and that's within the mental health system as well as that impact on law enforcement and first responders that I mentioned and their exposure to traumatic material. There are some typically in the larger institutions and the mental health centers, there's access to employee assistance programs and other types of programs. And there is some talk, or maybe in some parts of the country, I'm not aware of it happening in New Hampshire, but peer support type programs for mental health frontline workers.
Thanks. It's good to know that there are some. I'm sure we need to do more. Something if folks have more questions, we just got to the end of our queue here, so put them in for our last 10 minutes or so. In the meantime, I do have another question. So, I feel like mental illness has become something people are talking more about, in the last few years. It's becoming more salient, but I feel like a lot of times it's in the context of anxiety, depression, but still feel like there's a lot of stigma against more serious mental illness, thinking, so my brother had schizophrenia, just thinking, that it's an awkward conversation, even with supportive people. And then other people, they're afraid. It's obviously the media portrayals are still overwhelmingly negative. How do you think we start to shift that conversation? Obviously the work that NAMI is doing is pushing us in that way, but what are things that, folks who are listening today on the call can do in their own lives?
Well, thank you. That's an excellent question, and it's very pertinent and very insightful. And I think one of the things that people can do is do what you just did, and to say that you have a family member that that had that diagnosis. I think it takes some of the mystery and the fear out of it that has been largely media driven. One of the projects that we've been working on with support from the Bureau of Mental Health Services and together with Dartmouth is, and I would encourage people to go to the website, it's onwardnewhampshire.org or onwardnh.org. And it's about early serious mental illness, in which schizophrenia falls into that category. Is called in other parts of the country first episode psychosis, or FEP, but based on feedback from stakeholders, they didn't like that term of psychosis, and they're calling it early serious mental illness. It has videos and stories of young people and or their family members talking about it and how they cope with it and how they are, moving on with their lives. We should think of things like It's a Beautiful Mind, the film about the college professor, and how brilliant he was, and how he overcame that diagnosis and that label that he had. So again, I think it's in part seeing the person and not the illness, but there's a lot of work to do in that area, and to better understand, that these folks are people, that they can function well in our society, and that, when we talk about this population, one of the things that's really challenging is that we tend to talk about the most severely ill folks, and those are the ones that the media focuses on. Those are the ones that make headlines. Those are the ones that, that create fear. But the reality is that they are this very small percentage of people with those diagnoses. And again, I mean, that creates this dichotomy where the rest of those people don't want to identify or be identified because they don't want to be associated in that way.
Thanks. Another question here from Dennis. Has NAMI thought about providing some basic training for police standards and training to police academies or anything like that?
Yes, thanks, Dennis, for that question. NAMI for probably 15 years has provided training, a block of training at the police academy for every recruit coming through the academy. And that's grown over time. I think when we started, it was 4 hours, and then it doubled to 8 hours, and now it's 16 hours. And that includes de-escalation techniques. It includes presentations by people with mental illness, talking about their experiences with law enforcement, and it includes some role play. As we speak, we are closing in on the tail end of a 40-hour crisis intervention team training. We have 25 state troopers at that training, a handful of folks from municipal department, and some fire and EMS folks. And that is a CIT is an internationally recognized program, crisis intervention team. It was recommended in the President's Commission on Police Reform in 2016, and it's something that Governor Sununu included increased funding for in the budget this coming year, and I believe is still in the budget proposed by the Senate, and that would happen through the police academy. And that, again, includes significant pieces about de-escalation strategies, use of less deadly force, communication skills, role plays, hearing from individuals with mental illness and their families. We had been kind of stymied in our ability to offer that during the pandemic because it really needs to be done in person. But we're happy to be now at a point where people are vaccinated and we can start offering that in person again. We're going to be doing one in the coming weeks for the Department of Corrections as well.
Great. Awesome. Glad to hear you guys are doing that work. And Nancy, thank you for posting some links to 603stories.org and onwardnh.org. That's there in the Q&A box for folks if they want to save those links. So we're just right about at the end of our time. And I just want to say thank you again, Ken, for coming on this morning, for talking to folks a little bit about what's been going on in New Hampshire, the mental health space, and maybe some of the places where we can go moving forward. So really, really thank you for your time, and thanks everyone else for being here with us. This will also be available, the recording will be available on our website probably in the next day or two.
Thank you, and thanks. Keep up the great work that you're doing at the Carsey Institute. And thanks again for inviting NAMI New Hampshire to be on.
Absolutely. We'll be back in the fall. Our next event will be in September, so look out for that. We'll be taking the summer off. Hopefully everyone else gets some time away to recharge over the summer themselves. Again, Coffee and Conversations is a joint production of Carsey School of Public Policy at the University of New Hampshire, the New Hampshire Certified Public Managers Association, and the New Hampshire Bureau of Education and Training. Thank you all so much. Have a wonderful day.